Hi, everyone. Oh, there we go. Hi, everyone. Thank you so much for joining us today. So I'm Akalesh. I'm one of the education coordinators at SUPTA. And this week, we're going to be focusing on ENT and max facts. We're really excited to have you with us. So today, we're being joined by Katie Crabb, who's a fourth year from the University of Birmingham, who's going to be guiding you through this topic. And these sessions are quite interactive. So we really do encourage participating wherever you can, either whether that's through the chat or just unmuting your microphone and talking. And also, please don't hesitate to ask any questions. We can always try and pause to really go through them. And also at the end of the session, we'll share a feedback form, and that feedback form is tied to your attendance, as well as also some discount codes for Teach Me Surgery, Pass the MRCS, and Geeky Medics. And we also do have an exclusive question bank with some other additional resources, like the recordings for these sessions, and those are all on our learning portal, so be sure to go and access those. And just before we begin, I'd like to thank our partners, who are MDU, More Than Skin Deep, Teach Me Surgery, Pass the MRCS, and Geeky Medics. I'm going to hand it over to Katie now. Thank you so much.
Hi, everyone. So today, we're just going through ENT and max facts, so some key conditions that might come up in the UK MLA, and just if you're interested in the speciality, a bit of like an exploration into that a bit further. So these are the pathologies that we're mainly going to focus on today. So it's acute ear pain, so otitis externa, otitis media, acoustic neuroma, epistaxis, rhinosinusitis, and tonsillitis, and there'll be some different conditions that we discuss in between as well. So learning objectives, so the acute ear pain is mostly the anatomical and clinical, and then I'm not going to go through these too much, but just in your own time, it might be good to review that kind of thing. So firstly, we're going to start with the ear. So going on for the anatomy of the external ear, you have the auricle. So it aids in capturing sound waves and directing them through into the acoustic canal, the ear canal. And so essentially it's cartilage covered by skin, except at the lobule where it's slightly different. So you have the curvature, so you have the outer part is the helix, and then you have the antihelix in the inner part, as you can see in the diagram. So the concha is like a hollow depression which directs the sound into the external acoustic meatus. And then in terms of blood supply, you have the auriculotemporal branch of the superficial temporal artery, and then the posterior auricular branch of the external carotid artery, which tends to supply the other structures in the face as well. So you can see here kind of the diagram of all the labeled parts of the concha, antihelix, the helix, the tragus, and then you can see the external acoustic meatus going through there. So penohematoma, so kick-starting off with an emergency, and this is common in rugby players and wrestlers, and you have disruption to the cartilage today essentially. So the cartilage gets its nutrition from the perichondrium, so you have avascular necrosis of the cartilage where the two layers separate and therefore it can't get its nutritional supply, and you risk of that avascular necrosis and cauliflower ear appearance. So you can see that here. So it's really important that you have a same-day assessment by ENT and incision and drainage under local anaesthetic. And you can also wash with saline, antiseptic, and then match your suture with dental rolls to prevent reaccumulation. And you also want to do otoscopy to rule out a tympanic membrane perforation as well, particularly if someone is presenting with hearing loss alongside these signs. So talking a bit more about the external acoustic meatus, it's an S-shaped tube, so about 2.5 centimeters in length. And the main function, as you can imagine, is transmitting those waves that the auricle were helping to direct through, amplifying the sound and protection of the middle and the inner ear. So the external part has the cartilaginous wall, so it's got hair follicles, sebaceous glands, ceruminous glands, and the skin is thick and adheres quite loosely to the cartilage, so this part's quite flexible. However, the internal 2/3 is temporal bone, so it's a lot more narrow and more rigid, and there's no glands or hair follicles in this part. And the skin is very thin, so it adheres closely to the periosteum and has heightened sensitivity, essentially. And can anyone put in the chat why they think that this might be important? So why it's good to have an awareness that the skin's thin? Any conditions that might be related to that? I can't see the chat, so.
I'll read out if anything pops up. But if I don't, I guess assume that there's no messages.
Yeah, so essentially the skin is very thin, and it's important to be aware that in otitis externa, that's why the condition presents as painful as it does. You often find that people are in like a lot of pain when they present with otitis externa, and it's mostly because it has such a thin adherence that to the periosteum that it's very, very sensitive. So the direction of the canal is like superior anteriorly and superior posteriorly, and then goes like inferior anteriorly. So it's kind of the directions of the tube itself. And that's why it's good to like pull on the pinner when you're trying to do otoscopy, so you can make the canal as straight as possible. And then its narrowest point is at the isthmus. In terms of neurovasculature, I'm not going to talk too much about this sort of thing, but you can see here it's got quite extensive nervous innervation and contributes to a lot of different nerves, as you can see there. And epithelial migration is quite an interesting phenomenon. So essentially, the epithelial cells gradually migrate towards the external opening of the canal. So that's all the debris and things like that just gradually clear from the canal itself. And it helps to be dispersed completely via chewing or jaw movement. And then this is like a natural mechanism to allow self-cleaning of the ear. So this is why a lot of the time cotton buds and other cleaning methods are not necessary, because the ear has its own natural cleaning mechanism. So now talking a bit more about otitis externa. So it's inflammation of the skin and the subdermis of the external ear canal, which can also extend to the pinna, the tragus, and the tympanic membrane itself. So when it's acute, it means it's around under 6 weeks, and it's mainly driven by Pseudomonas aeruginosa and Staph aureus. And then if it's chronic, it can last for more than 3 months, and this tends to be much more of like a fungal cause behind the otitis externa. So some risk factors that are important to be aware of. You can see I've got like a swimming picture there. So swimming does increase the risk by 5 times, and this is mainly because Pseudomonas aeruginosa thrives in like water sort of environments. Humidity, trauma, external devices, basically kind of damaging the external ear canal itself, and then being immunosuppressed and having things like diabetes can increase your risk of otitis externa, and particularly malignant, like necrotizing otitis externa, which we will talk a bit more about in a second. So this picture here is a teenager with ear pain, history of swimming at the beach, and he has like wax and fungus. You can see it's like a fungal infection there. So essentially what happens to the external auditory canal is covered by hair follicles and cerumen producing glands. And the cerumen, so the earwax, essentially gives you a protective barrier, and it's an acidic environment that tends to inhibit bacterial growth. So if you have any inflammatory process that disrupts the natural pH, then you lose that protection and you can become much more vulnerable to bacterial overgrowth. So you can see here this pus in the external ear canal. So just on physical examination, you should always make sure that you're examining the auricle, the surrounding skin and lymph nodes, and doing otoscopy. So often you find this otalgia that is often disproportionate to the examination findings. So you might have like pain on moving the pinna or tragus. So these are actually red flags for necrotizing or like malignant otitis externa, which I will talk a bit more about in a second. So in terms of symptoms, you have pruritus, otalgia, otorrhea, fullness sensation, and hearing loss. And then on otoscopy, you might have an erythematous and edematous canal, which will be quite painful. You have yellow, white, or grey debris, and then erythematous tympanic membrane. It's a lot of the time, actually, you can struggle to visualize the tympanic membrane in general because the canal is just so edematous or pus-filled. So with uncomplicated otitis externa, you can give a topical antibiotic, and you might want to give a steroid as well. This is basically just based on your clinical judgment. If you believe that the external ear canal is not very inflamed, but there's evidence of pus and things like that, then you would want to give the topical antibiotic. However, if you feel like there's a lot of edema, the canal's quite swollen and inflamed, then you'd want to give that steroid to kind of calm down that inflammation as well. So if you have a perforated tympanic membrane, it's really important to be aware of not using aminoglycosides, and this is due to the risk of ototoxicity. And then you want to consider ciprofloxacin and an anti-pseudomonal cover. Essentially, that's why we offer that antibiotic. And then you definitely want to give analgesia because it's a very painful condition, as I mentioned, because the skin is so thin and adheres to the periosteum. And if you have non-resolving otitis externa with worsening pain, refer to ENT because of this. So malignant otitis externa is a medical emergency. So it's uncommon, it's potentially life-threatening, and tends to happen in people who are immunocompromised, like diabetics, older age, radiotherapy to the ear. So it does start off typically as simple otitis externa, but then it spreads to the suprahyoid neck spaces, so the parotid and masticated areas, and you have erosion of the cartilaginous bone of the external auditory canal and direct intracranial spread. And this is why it's such an emergency, because the complications include like osteomyelitis, subdural empyema, cerebral abscesses, meningitis. So a lot of really nasty cerebral complications just because of the inner ears, like the middle ear's location and just the way that the infection can spread. So here you can see granulation tissue in the middle ear. So some of the symptoms, you can have like severe, unrelenting, deep-seated otalgia that's out of the proportion of the examination findings. You might have temporal headaches, purulent otorrhea, and you can see the person starting to become systemically unwell. So in terms of treatment, you'd want to get microbiology involved, potentially do an ear swab or a sample so that can govern which antibiotics you want to use. And you want to give IV antibiotics for this. So IV ceftazidime and oral ciprofloxacin, and regular oral toilet, which is like microsuction, which involves cleaning out all the pus and debris. And basically, it's these sorts of major criteria, and all of them have to be made before you diagnose malignant otitis externa. Now talking a bit more about foreign bodies. So this tends to occur frequently in children, actually. So the presentation may be pain, deafness, or bleeding in discharge. And then on the otoscope, you might have bleeding where the object, say, abraded the ear or ruptured the tympanic membrane. And if you have a delayed presentation, you might have erythema, swelling, and then a foul discharge as well if it's been in there for a while. And the main thing you want to do here is removal of the object. So you can grasp the object with this hook here and then try and pull it out, or you might even need some suction as well. And children may require general anesthetic if they are a bit frightened or don't want to tolerate this kind of technique. So that is something that we do offer children too. So talking a bit more about ear canal microsuction, it's the removal of wax and foreign objects. So it's actually the gold standard method for wax removal, even though you don't really see ear wax removal being done as frequently anymore. And some of the indications is like clearance of obstructive materials, removal of material that's obstructing the view of the ear canal, and then removal of the foreign bodies as well. So it's kind of microscope guided, and styrene saline solution may be used to help break up the wax, and it tends to be much safer and more effective than syringing and irrigation sort of techniques. Now talking a bit more about the tympanic membrane, so kind of journeying through the ear itself. So it separates the external acoustic meatus from the middle ear, and it's connective tissue lined, and it's got a mucosal membrane on the inside. So it's composed of three main layers. So it has lateral layers like stratified keratinizing epithelium, the middle layers of fibrous stratum, and the medial layers like a cuboidal mucosal epithelium. So it's quite a translucent structure, and the handle of the malleus attaches to the tympanic membrane. You can see like the umbo. And it has anterior and posterior malleolar folds as well. So you have your pars flaccida, and then elsewhere the membrane is quite thick and tense. So you can see here the structure, and then the cone of light reflex there. So perforation of the tympanic membrane is important to consider too. So it is susceptible to perforation via trauma or infection. Most ruptures tend to be healed spontaneously, but large perforations may require surgical intervention like laryngoplasty. And some of the symptoms be intense ear pain that suddenly eases. So you may have a background about acute otitis media that's causing a lot of buildup of pressure, and then suddenly it ruptures and you find that the pain actually eases off, which is a sign that the membranes might have ruptured. So you might have mucus or pus coming out of the ear, or just discharge in general, hearing loss, tinnitus, and potentially vertigo as well. So for this, you can have a non-surgical management, so maybe a large piece of cotton wool covered in Vaseline to try and prevent the water entry into the ear. So it might involve like swimming earplugs, things like that, just while the small perforation heals. And then surgical, as I mentioned, is like laryngoplasty and trying to repair the membrane that way. So now the middle ear cavity. So it's air-filled, and it's a mucous membrane-lined space in the temporal bone. So it's got two main parts, the tympanic cavity and the epitympanic recess. and it has communication with the mastoid area posteriorly and the nasopharynx anteriorly. And its main purpose is to transmit those sound vibrations that have been passing through the external acoustic meatus through to the middle ear, and then amplifying and conducting those into the internal ear as well for processing. So it contains the chorda tympani and the facial nerve, which is important surgical considerations as well. And that's often why a complication of a lot of middle ear surgeries involves damage to the facial nerve. And then you have your ear ossicles as well. So you have the malleus, the incus, and the stapes. Talking a bit more about the tympanic cavity, and it tends to be quite like a rectangular sort of space, as you can see here. So it communicates anteriorly with the epipharynx via the eustachian tube, and posteriorly with the mastoid cavity via the tympanic antrum. So it has 6 walls. So it has a tegmental wall, which is like the roof, and it's formed by petrous parts of the temporal bone. It separates the middle ear from the middle cranial fossa. I'm not going to go through it too much in detail, but you can see here there's like different oval windows, like the digits of the mastoid antrum, a lot of communication with the other areas of the face and the cranium. And you can see it's got a lot of close associations as well. For example, the internal carotid artery, sympathetic plexus, which means that middle ear surgery can be quite dangerous and have increased risk of complications if you disrupt any of these important structures. Now, talking a bit more about the eustachian tube. So it's known as the auditorio-pharyngeal-tympanic tube, and its main function is aeration of the middle ear and equalization of pressure. Clearance of secretion, so that involves like mucus from the middle ear back through to the nasopharynx, and then protection of the middle ear against pathogens and sounds that are created in the nasopharynx. So you have the anterior wall of the middle ear, and then goes inferiorly, anterior medially, and then into the nasopharynx if you're following it through that course downwards. And it has a tympanic orifice and a pharyngeal orifice as well. So the tympanic orifice is the opening of the eustachian tube into the middle ear. The pharyngeal orifice is the opening of the eustachian tube into the pharynx, as you can imagine. And the osseous portion is the third that's nearest to the middle ear, so it can have variable numbers of peritubular air cells. And then the 2/3 closest to the nasopharynx is a cartilaginous component there. And they have 2 different kind of functions in a way. So you have both passive opening and active opening. So the passive opening, you can have positive pressure difference between the nasopharynx and the middle ear, which causes kind of the opening and closing. And then you also have active opening, which is driven by these 4 main muscles. So tensor velli palatini, levator velli palatini, sulpingopharyngeus, and tensor tympani. So they're also really important for the active opening of the eustachian tube and trying to equalize that pressure. For example, popping your ears on airplanes and things like that. And a good thing to be aware of is that the eustachian tube is more horizontal in children. So you can have an increased risk of infection spread from the nasopharynx to the middle ear. And that's why children do tend to present with much more ear infections than adults due to that kind of horizontal position. So now talking about otitis media. So this is inflammation of the middle ear space, and it's usually of an infective origin. And it's like a spectrum of different diseases involving acute otitis media, chronic suppurative otitis media, and otitis media with effusion, which is also known as glue ear. And it's most commonly seen in infancy, so 6 to 24 months, as I mentioned, because it's mostly to do with that position of the eustachian tube and how it's quite horizontal. It can permit bacteria and other pathogens to kind of travel into the middle ear space from the nasopharynx. And etiology, if it's virally driven, it's usually respiratory syncytial virus, rhinovirus, and enterovirus. And this basically precedes otitis media, and then most infections are secondary to bacteria. So the way it works essentially is the child or anyone that has acute otitis media may have presented with an upper respiratory tract infection, where you get a lot of inflammation of the upper airways, obstruction of the eustachian tube, and then you have an increase in negative pressure in the middle ear. So you have an increased exudate from the inflamed mucosa, secretions start to build up, which is the perfect environment for bacteria to colonize the middle ear. So you then end up with a lot of microbiome growth And it's essentially a disruption to the normal gut, the normal microbiome, sorry. And think about it in the same sense as the gut, because as you know, you have the gut microbiome, things can get disrupted, which cause a lot of diarrhea and other symptoms. It's actually quite a similar process in the ear where you get an overcolonization of a particular bacteria due to the disruption of the normal environment in the ear. So some risk factors would be a lack of breastfeeding as a baby, attending nursery, a positive family history, an age between 6 to 18 months, and exposure to smoking. And some of the really important complications to be aware of is like tympanosclerosis. So this is kind of white patches on the tympanic membrane, hearing loss, tympanic membrane perforation, because as I mentioned, you can get those secretions that cause a buildup of pressure, and then you get the rupture of the tympanic membrane. Mastoiditis, which is an emergency, and then facial nerve palsy. And the intracranial, obviously, you have your meningitis, the abscess formation, and cavernous sinus thrombosis, lateral sinus thrombosis, which are also important to think about. So on otoscopy, you can see here you have a very erythematous, inflamed tympanic membrane, which is bulging. So in infants, you might have fever, ear pulling, irritability, vomiting, poor cough, things like that. And in children and adults, it's important to be aware of like autalgia, fever, and hearing loss. And then on otoscopy, you can see these kind of changes here. So erythematous, yellow, or cloudy tympanic membrane, moderate to severe bulging, and then a loss of the normal landmarks like the cone of light reflex, things like that. And then you may even see a perforation of the tympanic membrane or any discharge as well. So the mainstay of treatment is like analgesia, antipyretics. Antibiotics are immediately prescribed if the symptoms are greater than 4 days with no improvement. One thing to bear in mind for exams, it's quite good to remember when you would want to prescribe antibiotics for acute otitis media, because it's something that does commonly come up in past paper questions. So essentially, symptoms that have been more than 4 days with no improvement, if they're systemically unwell but don't necessarily require admission, if they're immunocompromised or at high risk of complications, if they're younger than 2 years with bilateral otitis media, and if they have otitis media with perforation and any discharge in the canal. And it's usually a 5 to 7 day course of amoxicillin, which is first line, and then obviously erythromycin or clary if there's any allergies to penicillin, and if you don't have any improvement, then switch to coamoxiclav. And then commonly, as I mentioned, perforation of the tympanic membrane. If it's unresolved with perforation, then you get the chronic picture, so chronic otitis media and labyrinthitis, things like that. And if you do have recurrent episodes of otitis media, cholesteatoma is also another thing to think about, which we'll talk about shortly. So now talking a bit more about otitis media with effusion. So this is a middle ear effusion with no signs of infection. So it's a peak between 2 to 5 years of age. And the etiology is mostly eustachian tube dysfunction and also nasopharyngeal tumours. So that's when you get a unilateral middle ear effusion in an adult, which is quite a worrying sign. It tends to be asymptomatic or can present with some hearing loss. And the investigations mostly be like tympanometry, which shows a flat trace and reduced tympanic membrane compliance, or pure tone audiogram, which shows that conductive hearing loss. Another thing you can see as well, you might see bubbles behind the tympanic membrane if you do otoscopy. And most of the time it's a watch and wait approach, with 50% do tend to resolve. Just kind of watchful waiting after 3 months. And then laryngotomy and ventilation tube insertion is another option. That's when you insert grommets to try and help drain the fluid. You may also find that there's poor speech development in children or any general signs that their hearing is not quite as it should be. So essentially in children, the suture between the petrous and the squamous part of the temporal bone is still unossified, which can increase the risk of middle ear infections, which spread to the temporal lobe of the brain from acute otitis media. So in children, they are the age group that are most common to have otitis media, but it's also really important to think about these really negative complications just because of their more juvenile anatomy. So encephalitis, meningitis, and cerebral abscesses are a higher risk in children. And then in adults with a unilateral middle ear effusion, you have to ensure there's flexible nasoendoscopies performed to rule out nasopharyngeal tumour. And does anyone want to put in the chat why they think a nasopharyngeal tumour can present with acute otitis, with otitis media with effusion or glue ear?
There isn't an answer, but there was also just a quick question about how the lack of breastfeeding increases risk, and they asked, is it immunity-wise, or is it immunity-mediated?
To be honest, I'm actually not 100% sure why the lack of breastfeeding does increase the risk, but it's definitely something I can try and find out. And I think when a lot of the things, when they're associating with bottle feeding and breastfeeding, there's a lack of general evidence, but there is some like research that displays there is a correlation, but we're not exactly sure why. I think that can often tends to be the case with a lot of things related to breastfeeding.
And someone just said obstructing the eustachian tubes.
Yeah, that's exactly right. So it's obstructing the eustachian tube, so then that's why you get that kind of unilateral presentation of gluteal essentially. Well done. So now talking a bit more about cholesteatoma. So this is formation of a squamous keratinizing cells. So basically abnormal skin growth that advances from the superior tympanic membrane to the epitympanic recess of the middle ear and can cause local destruction of bone. So that's actually quite a serious problem. So they usually originate due to retraction or a defect in the tympanic membrane itself, and having cleft palate does increase your risk by about 100 times just due to the differences in anatomy essentially. And then in terms of features, you have foul smelling, non-resolving discharge. You may have conductive hearing loss, vertigo, facial nerve palsy, depending on how far advanced the cholesteatoma actually is. And then attic crust can be seen on the uppermost part of the eardrum when you're doing otoscopy, which is one of the main signs. And then a treatment is tympanoplasty if it's small, or mastoidectomy if it's infiltrating the mastoid bone. So you can see here that the cholesteatoma there. And it's actually quite interesting because despite being like a benign pathology, even if a few cholesteatoma cells remain when you're doing the operation, there is potential for regrowth, which I thought was quite interesting. So acute mastoiditis is an emergency, and this is when you have acute infection and inflammation in the mastoid, and it's a medical emergency. There is a risk of meningitis, mastoiditis, cerebral abscesses, so that's typically why it's such an emergency. And what tends to happen is that you can have otitis media, which progresses into the mastoid antrum, and it starts to get infection of the air cells. And it's mainly driven by strep pneumonia, Haemophilus, influenza, and Moraxella catarrhalis, which are the same pathogens that are common in acute otitis media. So some of the symptoms and signs that have otalgia behind the ear, and you might have protrusion of the ear pinna, and then tenderness over the mastoid process. And then the main treatment is antibiotics for medical, and then surgical may be drainage via a mastoidectomy or a tympanostomy. So you can see here the post-auricular erythema, which is kind of characteristic of mastoiditis. And that's why it's always really important when you're doing otoscopy or you're examining someone's ear that you always feel for tenderness behind the ear and looking at the mastoid process, essentially. Now the ossicular chain, so the auditory ossicles, the malleus is the largest, and then the incus is the long process articulates with the head of the stapes, and then the stapes is attached to the oval foot plate. So they essentially transmit the oscillations from the external to the internal ear, and you have muscles that attach them to regulate the movement as well. And then otosclerosis is when you have replacement of normal bone by vascular spongy bone. And it's an autosomal dominant condition that predominantly affects young adults and causes progressive conductive deafness due to fixation of the stapes at the oval window. And some of the signs is bilateral conductive deafness, tinnitus, tympanic membrane. 10% have like a flamingo tinge for hypoerythema. Positive family history, and essentially you want to do stapedectomy for management or use hearing aids. It's also important to be aware that the condition can present in pregnancy, which is a lot of questions that you might come across with otosclerosis becoming apparent in pregnancy. And then myringotomy, so it's kind of like the surgical procedure I was mentioning earlier. So it's used to drain fluid from behind the tympanic membrane. So a small incision is made and grommets are inserted into the cuts, and they act as ventilation tubes and facilitate equalization of the pressure of the middle ear in the external environment. So it tends to be used if you have recurrent acute otitis media, chronic otitis media with effusion longer than 3 months, and then tympanic membrane retraction due to eustachian tube dysfunction, essentially. And they do naturally extrude themselves as the eardrum heals. However, if it's longer than 2 years, you might want to consider doing an operation to remove the retained grommet, essentially. Yeah, and that's kind of just more about like the technique itself, which I'm not going to go too much into detail. And stapedectomy is, as I mentioned, the mainstream treatment of otosclerosis. So you have restoration of the normal transmission of acoustic vibrations to the cochlear fluid. And contraindications to be aware of is if the patient is particularly elderly, so older than 70 years, young children, athletes, so like snorkeling, parachuting, scuba divers, and pregnancy is an interesting contraindication because, as I mentioned, the condition can commonly present in pregnancy. So it's important to kind of do that operation after the birth, essentially. And then complications, you can have conductive hearing loss, sensory neural hearing loss, facial nerve injury, because as I mentioned, the facial nerve is in close association with the middle ear, vertigo, and then incus dislocation, the kind of typical middle ear surgery complications. Now talking a bit more about the structure of the inner ear. So it's a series of bony cavities, membranous ducts and sacs within the cavities. So you have the bony labyrinth and you have the vestibule. So you have 3 semicircular canals in the cochlea. And then the bony cavities align with periosteum and contain perilymph. And then the membranous labyrinth contains endolymph, suspended within perilymph and contains endolymph. And the main function is the organ of hearing, essentially, the cochlear duct, and it transduces energy from sound to electrical impulses, which are relayed to the brain for the interpretation of hearing. And then the 3 semicircular canals are important for balance, so they detect angular head acceleration and then linear acceleration of the head, basically your head movements and trying to maintain your sense of balance. So with human hearing, so the average human detects sounds between 20 to 20,000 hertz, and the cochlea is tonotopic, so high frequencies are at the basal turn, and then low frequencies tend to be at the apex. And then presbycusis is something to bear in mind. So this is sensory neural hearing loss, and typically is high frequency bilateral hearing loss that affects mostly the elderly. And it has quite a slow progression, and there's like multifactorial causes. So arteriosclerosis, you have decreased perfusion to the cochlea, diabetes has increased risk, and then accumulated exposure to noise. And then the vestibular and cochlear component basically of the nerve. So basically both fibers combine in the pons to form the vestibular cochlear nerve. So this journeys through, exits the brain at the cerebellopontine junction and exits the cranium via the internal acoustic meatus. So this is a narrow canal formed in the petrous temporal bone. And the lateral boundaries like the fundus, and then you have the falciform crust, which divide it into superior and inferior sections. So the superior section of the meatus has like cranial nerve 8, the superior vestibular nerve of basically cranial 7, and the superior vestibular nerve, cranial nerve 8. And then the inferior portion has the cochlea and the inferior vestibular fibers, basically those parts of the nerves. And the things it contains in general is cranial nerve 7, 8, the labyrinthine arteries and veins. So now from that anatomy, we go on to talk about acoustic neuromas or vestibular schwannomas. So this is a rare benign tumor of the vestibular cochlear nerve that arise from the Schwann cells. And they usually occur at the internal auditory meatus in the cerebellopontine junction, and they're almost always unilateral. And if it's bilateral, it does raise flags for neurofibromatosis type 2. And in terms of symptoms, you can have sensory neural hearing loss, which is common, and it's typically unilateral and progressive. You might have tinnitus and vertigo. They have an absent corneal reflex, and then facial weakness or numbness, and may have headache, nausea, and vomiting to do with raised intracranial pressure, which obviously tends to be a bit more late stage. So the most common presenting symptom is the hearing loss. So the investigations, you want to do an MRI of the cerebellopontine angle, which is the gold standard, and then audiometry as well. For management, it tends to be watch and wait for a lot of people because these can be quite slow growing tumors. But if you were to operate, you could do microsurgical resections. So these are the kinds of approaches. So translabyrinthine, retrosigmoid, or middle fossa craniotomy. However, the different surgical approaches are always decided by an MDT, and there's a lot of different factors which come into making a particular decision, particularly as some approaches mean that you can conserve hearing, while some approaches mean that the hearing in that ear will be lost completely as just a standard complication of that surgery. And then stereotactic radiosurgery is a non-invasive procedure which uses radiation to try and control that growth. So now we're going to move on to the nasal cavity. Does anyone have any questions at all at this point? So I know it's a lot of information, but I think it would be good in the case-based session to kind of recap on all the ENT that we covered today. Just continue. So the nasal function, so the primary function of the nose is essentially ventilation, but the other functions that can commonly get overlooked is like humidification, olfaction, mucus production. It has a lot of immune function as well. As you mentioned, the eustachian tubes, so ventilation of the middle ear and drainage of the nasolacrimal duct and resonance of voice as well. So in terms of the anatomy, you have the external nose, you have the bony component with the nasal bones, the maxilla, the frontal bones, and you have a cartilaginous component. So that's inferiorly with 2 lateral cartilage, 2 alar cartilage, and 1 septal cartilage. So you can see here in the image all the kind of the anatomy of the nose and the way the cartilage all kind of overlap with each other. And it's also, you have the danger triangle of the face. So you have the ophthalmic vein, which forms a communication between the facial vein and the cavernous sinus. So this can lead to infection spreading that way and causing thrombosis, meningitis, and brain abscesses as it infiltrates the cavernous sinus, which is in close proximity with the brain itself. So that's quite an important thing to be aware of. And then rhinopyma. Essentially, you have skin overlying the cartilaginous portion of the external nose, which contains pilosebaceous glands. And when you have hypertrophy of these glands, you have an enlarged, red, kind of bulbous nose, as you can see the very classic appearance here. And it does tend to begin with rosacea, and then it's more common in white men between the age of 40 and 60. So talking a bit more about the nasal cavity, you have the nares to like the guani. So you have the midline is partitioned by the nasal septum. So you have the maxillary crest inferiorly and the perpendicular plate of the ethmoid bone superiorly and the vomer posteriorly. And then you have your roof, which is formed by the sphenoid cribriform plate of the ethmoid, the frontal bone in the nasal bone, nasal cartilages, the floresma, the maxilla, palatine bone, and upper surface of the hard palate, you can see here. Then you have your medial and lateral walls as well. So this is quite a good diagram, particularly to go through in your own time, which shows all of the anatomy that's important for all the clinical correlations that we'll go through shortly. So you have the turbinates, which are bony projections in the lateral wall. So their main role is humidifying and filtering the inspired air. So you have 3 general regions. You have your nasal vestibules here in green, and then you have your respiratory region, which is the largest, and the olfactory region, which tends to be at the apex here. And it's lined by pseudostratified ciliated columnar epithelium. And it also has a different venous plexus as well, which can engorge in response to external stimuli, neural and hormonal changes. And this engorgement of the epithelium and kind of the hypertrophy of the turbinates is going to be really important when we talk a bit more about rhinitis. And then there's 4 main openings into the internal nasal cavity. So you have the sphenoidal air cells to the sphenoethmoidal recess. The posterior ethmoid sinus opens into the superior meatus, and then the anterior ethmoid sinus, the frontal sinus, and the maxillary sinus go to the middle meatus, and then the nasolacrimal duct empties into the inferior meatus. So you can see kind of that opening there. So olfactory nerve, essentially you have the olfactory mucous membrane, which is adjacent to the cribriform plate, and that tends to be where all of that process of sense of smell begins. And then in terms of innervation, it's mostly by the trigeminal nerve, the ophthalmic and maxillary divisions, and supplied by the anterior and posterior ethmoidal arteries, the facial artery and the sphenopalatine artery. And this is a combination of both internal and external carotid artery branches. So you can see here Little's area. So it's an anterior inferior nasal septum, and essentially it's an anastomosis for these different sorts of arteries that is very prone to nosebleeds. And then the paranasal sinuses, so you have four main paranasal sinuses, as you can see in the diagram. So you have the frontal sinuses, which drain into the lateral wall of the middle meatus via the frontonasal duct. You have the maxillary sinuses, which are the largest of the paranasal sinuses, and there's a lot of anatomical variation between individuals for this. And then you have your sphenoidal sinus, which is in close association with the sella turcica and the pituitary gland and just the cranium in general. And then ethmoidal cells as well. So talking a bit more about the anatomical variations, this isn't too important, but it's actually quite good from an ENT perspective to be aware that everyone's anatomy is slightly different and it can complicate surgical access and different procedures. So there's a lot of septal variations, there's a lot of like different turbinate variations, and it might mean that the patient may present with impaired nasal breathing and they have complicated surgical access because the septum is not necessarily as straight as in another person. You can have ethmoid cell variations, like halo cells, which are ethmoid cells develop into the floor of the orbit. So you have a much increased risk of orbital injury during ethmoidectomy. And then you have a lot of sinus variations. So the frontal sinuses are actually absent at birth and they're asymmetrical in size in general. Maxillary can have secondary septa, which can interfere with procedures, and then the sphenoid can have optic nerve protrusion into the sphenoid sinus. So these are just some important anatomical variations that might be helpful if you're like considering different surgical approaches for ENT. It might be a good thing to ask like an ENT consultant on placement how they manage surgery with these different sorts of anatomical variations as well. So now talking a bit more about the nose emergencies. So massive epistaxis is a big one. So most epistaxis involve Little's area, or the Kaiserback plexus, which is the one that I mentioned earlier, where essentially branches of the external carotid artery, and then bleeding is usually visible. And this is typically more children and young adults. Whereas a posterior hemorrhage tends to affect Woodruff's plexus, which is occurring at the posterior end of the middle turbinate, and it's a venous plexus. So supplied by the phenopalatine artery in anastomosis with the posterior pharyngeal artery, but then it comes into more of the venous circulation, which is that sort of, the plexus is more like the venous supply. And it's the most common posterior hemorrhage site where you can get profuse bleeding that's at significant risk of airway compromise. So it's really important that you manage this appropriately because there's actually a lot of unnecessary fatality from massive epistaxis that can be avoided. And this tends to be the older population with a background of like hypertension or atherosclerotic disease. And the etiology is mostly like local, so that might be things like trauma, neoplasia, cocaine use, systemic, which is like hypertension, coagulopathies, von Willebrand disease, hereditary hemorrhagic telangiectasia, vasculitis, environmental, so allergies, and then dryness in the winter season as well. And then NSAIDs, anticoag, and then topical steroid sprays. So the first thing that you want to do is sit upright with the head tilting forward with first aid and then pitch the fleshy part of the nose. And you really want to instruct patients to spit out any blood going down the throat. Does anyone know why you want to do that aside from the airway related things? Does anyone want to put it in the chat?
Someone said because blood irritates the stomach and causes vomiting.
Yeah, that's exactly right. Yeah. So essentially, swallowing blood is hematogenic. So the patient is much more at risk of vomiting, and then the complications of vomiting, which may result in them like blocking the airway even further. So obviously, that's something we want to avoid. So you want to observe for around 15 to 20 minutes. You can consider putting ice in the patient's mouth for vasoconstriction, and after the bleeding has stopped, the first thing you want to do is try and inspect the nose using a nasal speculum, because this will determine whether you will be able to use like cautery and other techniques as opposed to like anterior posterior packing. Where the blood loss is extensive, obviously you should always assess hemodynamic status and continuous measurement of blood pressure. So if you're in an OSCE situation where you're presented with someone with epistaxis, it can be quite a good point to say that you'd want to monitor their blood pressure, can help to boost your marks there. And then some of the options, so topical treatment would be like vasoconstrictors, tranexamic acid, and cauterization with silver nitrate, particularly if the bleeding site is visible. Anterior packing, so that's when you have like a special nasal tampon or BIPP, topical analgesia that can be inflated and activated by water. And you can put this on the floor of the nose to stop the bleeding and then reassess in 20 minutes. And posterior packing, to be honest, is very rarely done because it's quite uncomfortable for the patient. It's when you kind of insert the urinary catheter down the back of the throat and inflate the balloon to try and prevent the bleeding. Endoscopic artery ligation. So essentially this is if the other options have failed. And in order of severity, you'd want to ligate the sphenopalatine artery first, and then the anterior ethmoid, then maxillary, and then the external carotid, which obviously we want to avoid as much as possible. And then with traumatic epistaxis, the anterior ethmoidal artery is usually the one that's implicated, and you want to do ligation via excision of the medial aspect of the orbit. And eye intervention is like permanent embolization of the maxillary artery. So this is very, very rarely done and only kind of in extreme cases. So now talking a bit more about septal hematoma. So this is a nasal trauma complication. So protrusions can be visible. As you can see here, they're typically kind of like the bilateral boggy appearance. You can actually see where it is there. And it's a hematoma, so much similar to the pinna hematoma. You have the disruption of the layers of the mucoperichondrial and the septal cartilage, so it disrupts the cartilage's supply, and you risk avascular necrosis and then nasal collapse, so you get like a saddle deformity of the nose. So you get irreversible necrosis within 3 to 4 days. So obviously, it's an emergency. Septal rupture, and then abscess formation as well. So what you want to do is incision and drainage under general anesthetic. So as opposed to the pinna hematoma where you did it under local anesthetic, for this one it's generally done under general anesthetic. And antibiotics can help to prevent septal abscess formation, and then you want to do anterior packing as well. So for a fractured nose, there's no need for x-ray. So you want to assess for the septal hematoma. And if there's swelling and extensive bruising, it's better to review in 5 to 7 days in ENT emergency clinic. Before then, you want to do the manipulation under anesthetic, essentially. And then the patient can wear splint afterwards for a week. And it can't be done really after 14 to 21 days, and you kind of have like more permanent deformity of the nose by then. So rhinitis and rhinosinusitis. So rhinitis tends to be inflammation of the mucous membranes of the nose. So you can get symptoms like nasal congestion, rhinorrhea, sneezing, itching, postnasal drip, and there's a lot of allergic and like non-allergic causes. And then rhinosinusitis is that includes the paranasal sinus. So it's very similar symptoms, essentially, like anterior and posterior rhinorrhea, and then nasal blockage and reduction in sense of smell. So you can do things like allergy testing to try and figure out what a trigger might be. So allergic rhinitis is IgE mediated, so it's a type 1 hypersensitivity, and it is associated with atopy, so that's including eczema and asthma. So the causes, if it's intermittent, it's mostly like seasonal, so like hay fever, grass, tree pollen. If it tends to be persistent, it might be more like pets or the house of dust mites, and like molds, things like that. So you have inflamed nasal turbinates and mucosa, and it tends to be a bluish and pale hue to the turbinate mucosa when it's visualized. Might have watery nasal discharge, and then gross turbinate hypertrophy, which I mentioned earlier, and you can get kind of hypertrophy of the turbinates. So it is a clinical diagnosis, and you can do serum RAST, so that helps to look for specific IgE to an allergen. And the main thing you want to do is kind of avoid the allergen itself, nasal douching, barrier ointments, oral non-sedating antihistamines, intranasal steroids, and then combination steroid and antihistamine, essentially. And then acute rhinosinusitis is when you have sudden onset of blockage of like nasal blockage, obstruction, or congestion, facial pain and pressure, a reduction or loss in the sense of smell for less than 2 weeks. So it's a much more acute sort of picture. And the main cause is like rhinovirus, coronavirus, influenza, and RSV. But you can also have bacterial causes, which are much the same as the acute otitis media bacterial pathogens. And then symptoms would be facial pain, anosmia, dental pain, so infection can spread to the sinuses. You have fever and malaise. You can also have a double sickening phenomenon as well, which is when you have a very mild onset of symptoms and then you feel like the patient might be getting better, but then suddenly they have an acute worsening of their condition, which tends to mean that they've had a bacterial cause behind their rhinosinusitis. And then complications are quite serious as well. So you have intracranial like meningitis, cavernous sinus thrombosis, intracranial abscesses, and then extracranial tends to be like osteomyelitis and then cellulitis, things like that. So in terms of treatment, if the symptoms are like less than 5 days and quite mild, you can treat with conservative management and nasal decongestants. If the symptoms are greater than 10 days or worsening after 5 days, then you want to consider giving intranasal steroids. However, if it's severe, then always give broad spectrum antibiotics for 7 days. So that tends to be amoxicillin. You might want to give steroids alongside that. So you can see here that this picture, you have mucopurulent discharge from the right middle meatus, so it's a bacterial-driven infection there. And then chronic rhinosinusitis, so this tends to be like inflammation of the nasal mucosa, paranasal sinuses for greater than 12 weeks. So you can have it with or without polyps and has a huge multifactorial array of causes. And then symptoms, mostly inflammation of the nose and sinuses, which cause like nasal blockage, nasal discharge, facial pain. And the main management is like medical, so saline irrigation, decongestants, but ultimately you have the surgical option of FESS. So septoplasty and septorhinoplasty is essentially remodeling the nose to improve the functional nasal airway, and then better access for endoscopic procedures as well. So septoplasty is straightening the nasal passage, but with no change to the external appearance of the nose. And septorhinoplasty is when you have like the functional benefits, but also reshaping of the external appearance. So this tends to also be known as like a nose job, just in colloquial terms. So the technique is mostly like lifting the nasal mucosal lining to lift it away from the septum bilaterally, and then stabilization ultimately with splint cell packaging when you're realigning the septum internally. And then function endoscopic sinus surgery. So the aim is to remove disease in the osteomeatal complex for restoration of the natural drainage pathways of the sinuses. So the main indications is kind of acute or chronic sinusitis that's not relieved by medical management. If you have any nasal tumors, drainage of mucoceles and pneumatoceles, and essentially you can take a lot of samples for cysts. Microbiology swabs can be taken and biopsies of polyps or abnormal tissue. And obviously you have your normal complications like epistaxis, infection, nasolacrimal duct injury, things like that. And then cleft lip and palate. So this is when you have a gap or split in the upper limb and roof of the mouth. So it's an abnormal connection between the oral and nasal cavity. It's kind of a failure fusion defect and tends to be congenital. It's the most common facial birth defect in the UK. So it's actually 1 in 700 babies, which is actually a lot more common than I expected. It's a vast array of different etiologies, and then some of the problems that can occur is the infant might have difficulty feeding, vulnerable to glue, ear and infections, dental problems and speech problems, and then you have surgical intervention. So if it's just a cleft lip, you can have it done between 3 to 6 months, and if it's cleft palate, then you might want to wait for it to be 6 to 12 months. Now we're very quickly going to go through head and neck, so tonsillitis and tonsillectomy, if anyone has any questions about the nasal cavity so far. I'll take that as a no. So now just the anatomy of the oral cavity briefly. So you have 5 muscles of the soft palate, so tensor vello palatini, levator vello palatini, which descend into the palate from the skull base. Palatoglossus, palatopharyngeus ascend into the palate from the tongue and the pharynx. And then you have musculus uvulus, or just like the uvula. So palatopharyngeus depresses the soft palate and then moves the palatopharyngeal arch towards the midline, helps to elevate the pharynx. I'm not going to go too much into the anatomy detail, just more about the clinical stuff. So these are both innervated by the vagus nerve, which is quite important. Wardier's ring. So the tonsil is essentially a collection of lymphatic tissue located within the pharynx. So it has all your motor tissue like T cell, B cell, macrophages. And it's in a ring arrangement. So the pharyngeal tonsils, when they're enlarged, they're known as adenoids. You have your tubal tonsil, which is around the eustachian tube in the lateral wall of the nasopharynx. The palatine tonsils are located within the tonsillar bed of the lateral oropharynx between the palatoglossus and palatopharyngeal arches. And then the lingual tonsil is the thing that's responsible for the irregular appearance of the tongue. So as you can see here in the diagram, you can see all the locations of the ring-like structure of the tonsils. And this is important for things like tonsillitis, which is an infection of the palatine tonsils, and it's mostly driven by group A beta hemolytic streptococci, which is the most common bacterial cause. And then symptoms would be sore throat, adenophagia, dysphagia, earache because of the referred pain from the glossopharyngeal nerve, systemic upset, and then if it's a viral-driven cause, it may present but with much less severe symptoms. And the main signs to be aware of, like pyrexia, swollen tonsils, and trismus, which is like lockjaw, which can be a sign of a peritonsillar abscess or quinsy, bilateral cervical lymphadenopathy, and then, as mentioned, the complications is mostly just abscess formation. And in terms of treatment, you can do like analgesia, of course, topical, and then fluid resus. And you want to use the Centaur criteria to guide antibiotic use, which is phenoxymethylpenicillin. So this is things like pus on the tonsils, so tonsillar exudate, pyrexia, absence of cough, and tender cervical lymph nodes. So those are all signs that it's a bacterial cause and you might want to start giving this antibiotic. And obviously admit if the patient is systemically unwell. Then tonsillectomy, ultimately. These are the sign guidelines for when you would want to consider a tonsillectomy. And then contraindications is mostly coagulopathy, acute infection, and cleft palate. And now post-tonsillectomy bleeding. So should always be assessed by ENT and can be subdivided into primary hemorrhage and secondary hemorrhage. So primary hemorrhage tends to occur within 24 hours, however, most commonly 6 to 8 hours post-op, and then fibrin clots can develop on the tonsillar fossae, and it's managed by the immediate return to theatre. And then secondary hemorrhage is greater than 24 hours after surgery, and essentially proliferation of the fibrin clot occurs. So by day 5, there's like a thick clot, and it tends to be associated, if it's 5 to 10 days after, it's more associated with wound infection. So it has a much bigger role for considering antibiotics. So this occurs in around 1 to 2% of all tonsillectomies, but when you consider how frequently tonsillectomies are done in the NHS, it's actually quite a serious complication we have to be aware of. And peritonsillar abscess, so it's an acute complication of bacterial tonsillitis, and it's a collection of pus that forms in the peritonsillar space, and it pushes the effective tonsil inframedially into the oropharyngeal space. And it's more common in teenagers and adults because it often results from untreated or only partially treated tonsillitis. And again, it's driven by those same sort of pathogens, and it's the most common deep infection of the head and neck. So symptoms would be like fever, a sore throat which lateralizes to one side, trismus, lockjaw, and like a hot potato voice. This is when the speech is thick and slurred, and you have the deviation of the uvula to the unaffected side. You may also have referred ear pain. And the main management of this is review by ENT, needle aspiration or incision and drainage, followed by IV antibiotics before and after. And then tonsillectomy may be considered to prevent recurrence, and then you may want to give systemic steroids like dexamethasone. However, this varies with local practice. These are my references. And thank you so much for listening. I hope that you find the session useful. And if anyone has any questions at all, then feel free.
Thank you so much for delivering that session. And you kept a remarkable time as well.
Yeah, no worries.
With the number of slides, that was really impressive. Thank you everyone for coming. And again, thank you so much, Katie, for delivering that session. So the feedback form is also in the chat below. And we've also got some other links like to our social media. So remember to please fill out your feedback form for your certificate of attendance and also your discount code for Teach Me Surgery and pass the MRCS. And our next session is also going to be covering ENT and Max Facts. It's going to be on the 5th of March, this Thursday at 7 p.m. But that's going to be a bit more of a case-based session, so a bit less of a lecture and sort of more engagement. And make sure to follow us on our social media platforms, for which the links are available in the chat, to receive updates on upcoming sessions. And we'll also be posting SPAs on our socials for additional practice, so please keep an eye out for those. And again, don't forget to visit our website, where we have a lot of resources like question banks, recordings for these sessions, summaries, and a lot more. And to access them, you can create an account on our learning portal. And we really hope you enjoyed today's session and found it really valuable and engaging. And thank you again for joining us. And thank you again, Katie, for delivering the session. And we look forward to seeing you next time.
Thank you, everyone.
Just checking to make sure that feedback link works. Is there anyone that hasn't been able to open the feedback link just before we end the broadcast? I'll take the silence as a yes. Anyway, thank you guys so much for coming.